Tonight's guests are some of my dear friends and some of the experts in our community here in San Antonio. Jason Redwine has been with my practice now for 3 months. We have Dr. DeRoche from Urosi. So we're going to hear a lot about Urosi's philosophy and how to treat patients conservatively. Also, a good friend of mine who treats many of my patients, an expert in the community, Dr. Manuel Ybarra, a pain management doctor, and we're going to give him his perspectives. But here's some things that we all know. But I mean, back pain is one of the #1 reasons why we miss work. We seek doctor care, days off work. I mean, it's a huge things that affect us. From the time to time, average American may have bouts of back pain once or twice a year, and some of us, unfortunately, and the patients we see suffer their lives. It's more significant. It affects how they move, how they feel. And pain, as we all know, is really a horrible thing to live with. Our experts today are going to be talking to you about how to deal with pain, how to get over the injuries, get over your back pain, and get back into your life. There are many things we're going to talk about tonight, some warning signs for you guys out there. We're going to talk to the experts about the back pain is back pain, but there are a couple of things that are warning signs that you need to look out for. We'll go over those things tonight. We're also, we're great. We have a patient that we're going to present to the audience, and we have experts that are going to start giving her advice of how to help her with her back pain that she suffered with. So my first guest tonight is Jason Redwine. Yeah, you're on. So Jason, I was very happy. Jason's been with the practice now for 3 months. And Jason was a chiropractor prior to early in his career for 12 years, then went on, went into nursing school, and then became an assist in surgery. And I know you graduated like top of your class, right?
Yeah.
Right. So tell me a little bit about yourself.
So, you covered, I did chiropractic care, worked in large offices, saw lots of patients. We did physical therapy, exercise, and then of course, the adjustments, and did that for 12 years and just kind of wanted to change perspective and work on the other side. And so went back to school, got a nurse practitioner degree, went straight into orthopedics, started doing extremity orthopedics and spine orthopedics and assisting in surgery, and here I am.
Well, one of the things in our practice, when you came to see me in our practice, was the first thing is we treat people with conservative care. And for that, what it means is, and it's kind of strange for surgeons and to think about this, but we really want our patients to get better without us. Right. Now, we can help you, and when you come to see us with your aches and pains, and particularly back pain or leg pain or arm pain, to understand what you have, go through some diagnostic tests. We'll go over an MRI tonight and show that. But we employ a lot of other expertise in our office, and not just in our office, but also in our community, to help patients recover from injury. So on an average day, we see patients with back pain.
All day long.
All day long.
I think that's one of the things that drew me to this place is the conservative approach. With my background, that's something I like. But yeah, we see patients all day long. And I would say a majority of them have either tried conservative care, or if not, that's the first thing that we go to.
Right.
Surgery is always an option, but we try and save it as the last option when possible.
And when we're talking about conservative care, is all things other than surgery. Mm-hmm. Surgery, as what we teach our patients and our members in our team, is that surgery is last choice, last resort. Right. It's not the first option anyone should consider. And there's many ways to help patients either manage or heal with their symptoms and get better and back in their lives.
Right.
So when you see a patient initially, what are some of the things that you ask patients when you first start to interview the patient?
So, it's always important to get a good history. So I always want to know what's bothering them, what's causing the problem, when do they notice it, where is it at, where does it go, stuff like that. Second, then what have they tried? And, have you tried stuff at home? Have you seen any other doctors? And how's that helped or not helped? And then that gives me an idea of where to start with them. Of course, we look at imaging and other diagnostic tests, but it always helps to know what the patient's had.
What kind of imaging are you talking about?
So here in the office, we get x-rays, which can be very important. Helps us establish how your joints are, how they're moving. Is there any instability? Usually patients will come in with MRIs. And so that helps us see other things like, nerve pinches, again, some instability, things like that, other things that might cause problems with the nerves and how they might be affecting your back.
Sure. So we start with an interview with the patient. It's called we call it history presentation, which we kind of get to interview the patient. And then what's the next part of our examination?
So then we go through the exam and we do a very detailed neuro checks. We're checking sensory and motor. We put you through some very provocative tests to try and elicit your pain. And then based off of that, we can get a good idea of what's going on and match it to any imaging that we got. So it helps us to correlate not just what we're seeing on the picture, but what the patient is feeling, which is important. It needs to match.
It needs to match, right? The patient's history, what they feel, and which is what we think of as subjective findings, what the patient tells us. And then we match that to objective things.
Right.
After that, we come up with a plan, right?
Right. So from there, it depends. If they haven't done any treatment, then first thing I always tell people, there's 4 general types of treatment. So it's the very conservative things like chiropractic, physical therapy, other therapies, massage, acupuncture can all be part of that. Then we go into medications. So these are usually oral medications, and then get a little more aggressive with pain management, maybe injections and stuff like that. And then surgery is the last general topic.
Sure. I think of patients, my professor was this old Southern guy that would talk to me about, we're going to see patients and he's going to talk about what he called, and I'll tell you every day in clinic, I tell you, it's you're either a have to or a could.
Right.
Right. And interesting, he said, you're going to see patients and they're going to be in pain, and everyone's pain is subjective, but the have to patients are different than the could patients. And for what he was teaching me was that the have to patients are things that when patients come with these set of problems, these are things we have to do.
Right.
Like, for instance, cancer, right? Infections and tumors, and someone's getting paralyzed. That he would say, Frank, that's one of the have to patients. You got to do something about that.
Right.
But thank the Lord, those aren't the majority of patients we see. We see them once in a while, but most of the patients are the coulds.
I think most of them are the coulds. Every once in a while, we have people that are maybe a little more urgent, but still not have to.
Not have to, right?
I think that's the nature of what we are. It's more elective type surgery based off of what you're feeling and how it's impacting your life. I think quality of life is one of the things that I talk about with patients. Is how is this impacting your life? And then that helps guide what direction we're going to go.
Certainly. I know that anyone that suffered back pain knows it does affect our lives, and it affects, not only who we are, but how do we interact at work, how we interact with our family and our loved ones. And it's really an encompassing problem.
Right. Absolutely. Everything from work to home to sleep, it can really impact your whole life.
Well, first of all, thank you for joining our team. You've been great on our MD Spine Care team, and I know your wealth of knowledge has been great, as well as your approach to conservative care. It's welcome on our team, and I know our patients like seeing you, and also, they're getting a lot of your years and years as a chiropractor, nurse practitioner, and now as a surgical assist. So thank you.
Thank you.
So I'd like to now introduce Dr. DeRoche.
Hello.
Hey, Jason. Hi. Hey, thank you very much for coming. So
you're welcome.
So I'm going to brag around a little bit about Dr. Rose. Dr. Rose is a treater, therapist, chiropractor from Urosi, and a lot of people may not know about Urosi. I have a long history with Urosi, and see its benefits, and first of all, tell me a little bit more about yourself.
About myself, I'm Jason DeRoche, and I've been in San Antonio for about 13 years. I've been working with Urosi for that entire time. And what attracted me to Urosi was their core values and how they approach patient care, and what they're looking for is to always do what's best for the patient as quickly and as effectively as possible, whether that's management solely under our care or co-management with other providers. And so it's been a fun ride, starting from the beginning all the way through 13 years that I've been there.
One of the things I'm impressed about, you guys get results. And like you said, you get to the problem, you diagnose the problem, and you get results quickly with the patients. And that's huge. As today we're all busy, and we have lives and things and all these commitments. But what I've seen in the patients that we've shared, that you get to the problem, you treat them, and they get better quickly.
Yeah, what's really nice about the treatment itself is it's sort of diagnostic in itself. So we go through all the standard history. We do the ortho neuro exams, make sure there's no weakness, determine what type of pain the patient has, and then decide if they're a candidate for treatment. And then if we move forward, we know within a visit or two, we should be seeing some change. If we're not seeing change, that's a flag for us. So that's when we start starting to consider what's our imaging options, what's our referral options, and what else do we need to include on this care to get the patient better?
Sure. So what's your typical patient? Is it the athlete that gets injured, or is it more like the older person like me that has a weekend warrior that gets an injury?
Yeah, we see all walks of life. We definitely do see athletes from the middle school all the way to the professional level. We see desk jockeys and people who travel often, the reduction in core strength over time, and postural adaptations that lead to putting more stress on the back. And so we see a wide variety. It's not only for the weekend warriors, it's for the everyday commuter and for the desk worker as well.
You know, one of the things we've seen in our practice is that during our COVID time period, you know, people used to go to work. Now, a lot of us we go to work, but a lot of people are working from home.
Right.
Have you seen that impact in patients and things like that?
Definitely. The ergonomics have changed dramatically for patients when they're working at home. They're working on the corner of their couch, or they're working on the kitchen table, and it's not quite set up the way that ergonomic stations that we've over the years developed inside of a lot of businesses. So it has definitely contributed to some increased loads on the back. Patients also are hit or miss on the exercise portion, so they're deconditioning as well by staying indoors. So we're seeing some of the weakness in core as well.
Oh, absolutely. You know, you wake up, if you didn't have to go to work, you know, friends of mine are like, gosh, am I going to get up and work out today or not? Right. And a lot of times, you know, unfortunately, or fun person, they're like, no, I'm too much, hit the snooze button and I'll be at work later. Or, and I find myself, you know, when I'm at home and when we had to shut down medically, and, you know, in San Antonio, we had to shut down for a period of time, and we were 100% telemed, and that's a great option. But I was at home on a desk doing work, and that's very different than the way you and I both work. We're physically active, we're moving all the time and treating patients. And I started to see neck and back pain that kind of had been quiet for me for a period of time come back. And I started just thinking about posture, about being like this for hours, or looking into a camera through a computer. Right. And so any tips that, you know, patients, so some of our audience are still working from home, right? So, and certainly with COVID, you know, we don't know what's going to happen the next couple of months. What are some tips that you could give our audience tonight about how to, you know, maintain posture, core strength, things like that?
Sure. There's some simple techniques and ergonomic stances. You make 90 degrees at your hips and your knees, and sitting up straight.
So 90,
90, and have this here. We're not overreaching with our ergonomics in this direction here. The big correction is really taking breaks, right? So what gets people is being in one position for too long. So sitting could be painful, standing could be painful, but either one of those will both be painful if we do them too much. Right?
Have you ever seen people use the sit-stand stations?
We do. We have them all the time. And my recommendation to them is like, oh, if I could just get a stand-up desk, everything would be great. My recommendation for them is change, right? So we don't do one or we don't do the other. We just sort of mix it up throughout the day. And that's what makes it change in the core and the way the body handles distributing the stress through the spine.
Sit-stand stations are something that I got introduced many years ago, and actually it was a call center here in San Antonio, and I went out to visit them because I was seeing a lot of people with some problems. And I met with the HR department, and they said, "Hey, what do you think about this?" And now we see it in Costco and you can buy it online, but it's a desk that goes up and down to accommodate, you know, if it changes during the day. So we use that a lot with recommendations for our patients, and certainly give prescriptions to the HR departments to help them. So what do you recommend sitting and standing? Is there a time guidelines, or what do you think?
Yeah, I get them at minimum to split the morning. If they're working an 8-hour shift, you need to at least in the morning stand up and do a little bit of engagement of the core. So I'll give them some nice easy core exercises that they can do right there to comfort in the home without any equipment, just enough to get the blood flowing. Then they can maybe stand for the rest of the morning, and then they can go vice versa in the afternoon.
That's very good suggestions. I don't know if I'm too lazy. So I know how to start my day. And when I was working at home, I start my 90. But I'm going to tell you, after a second cup of coffee, talking to a few patients, I inevitably start to do my slouch, and then it gets back pain. I start getting my leg pain and things like that. So, you know, I think for us, we just have to be mindful. If we are having to work from home, if we are having to, spend a lot of times in computers and desks and as part of your job, I think that mindfulness helps.
Yes.
Hey, what do you think about those ball chairs?
The ball chairs,
that
was around for a while, and it is an interesting way to get the core involved and helps you be more cognizant of your posture. That's there, and the same recommendations at desk is I like patients to actually mix it up for me, because if they sit on the ball and they sit on the ball, like you said, all day long, even on the ball, you'll start seeing the slouching. But if it's a one afternoon a week or 3 afternoons a week that they do it, then they pay attention more, and then they sit up more, and they have more of those body cues. We all want to sit up after we talk about it and then fix our posture and go through it. So we know it's right. It just gradually catches up to us over time.
I have to admit, I have one at home, and I don't use it. It sits in the corner.
Right.
And so one last thing I want to ask you, and many of us know in San Antonio, Urosi, and across the United States now, what would you think is the biggest difference, if there is a biggest difference between a traditional physical therapy program and Urosi?
Sure. So
help us understand.
Yeah, absolutely. We come a lot more from the chiropractic world, and then we integrate into the physical therapy world.
I think that's great.
And so it's much more hands-on, it's much more direct, and we do manipulation, not in terms of spinal manipulation. We do a lot of soft tissue manipulation, so muscles, ligaments, tendons, and we assess the patient's movement and their movement patterns when they come in. We decide what's tight, what's not tight, and what's impacting their ability to move appropriately. And we focus on those tissues. So in a lot of cases, we're not always focusing exactly where they're hurting, but some other areas that may be contributing and increasing stress in those areas.
I think, number one, we all know motion is natural.
Yes.
And so we have to, I like that about Urosi, the assessment of motion, as well as getting that the functionality back in the patient.
Right. And then we'll always add on the second half of treatment, which will be core strengthening, the more traditional rehabilitation therapy exercises that people would be familiar with. And
Perfect.
So we really think the magic to the treatment is kind of marrying those two together, having the patient understand what's contributing to their symptoms, help with things ergonomically and lifestyle coaching, if it's losing weight or sitting better at a desk, or which core exercise they need to keep up with.
Be careful there. You hit a hard topic here, weight reduction. So be careful.
And we do that. And then we work with flexibility quite often as well. Use rollers and balls and other things that are out on the market to try to help people with self-care.
So with flexibility, can't hold my backswing for golf? Yeah.
We can give some tips and tricks for sure.
I need those. So our next guest will be Dr. Manuel Ybarra. And Jesse, if you have to here. So Dr. Barr, well-respected pain doctor, anesthesiologist, here in San Antonio. And I've known you for how long, you think?
12 years.
12, long time. Right? I know we didn't have this before.
No, there was no gray.
There was no gray, right?
Yeah.
And if we die, we'll talk later.
No, we will not die.
So anyway, long story short, Dr. Barr is one of the doctors that I rely on in treatment of my patients, and certainly his specialty is anesthesia and pain management. And I truly, in our care, we use all measures to try to get people over their injuries, and particularly back pain, and also some of their symptoms, and back into life with using physical things and Urosi and motion and dynamic and functional strengthening, core strengthening, but sometimes they hurt, right?
Right.
So that's how you get involved.
Right. Yeah. No, I get involved to help facilitate the other measures to get them where they need to be, whether it be blocks so they can do the Urosi or physical therapy or chiropractic care, if that's necessary. Sometimes they can do it without blocks. So just depending on the patient.
So what are some of the things when you first see a patient, what are some of the important things that when you start evaluating a patient that you think are important to see if they're good candidates for pain management?
Yeah, every patient comes at a different step of the process. Sometimes I'm the first physician they're seeing with that complaint. Sometimes I'm the fifth. They've come from you already. So we always take, full assessment with regards to their medical history, personal history, what they do at work or at home, and some of their stressors. And factor that in and see what they've done already to treat the issue or what they haven't done, and focus on that and try to see what options we have to get them better. I always tell patients our job is to teach them what's available for them. And together we choose, what approach we're going to take.
Give the patient options, right?
Right.
But I agree, a lot of it's educating our patients that this is your problem, and defining what the problem is, whether it's a herniated disc or muscle injury or ligament injury, and then educating the patients that these are treatment options that can help.
Right.
Right.
Especially since I'm dealing with such subjective issue of pain, right?
Right.
Objectively, we can see what's on the imaging, but at the end of the day, how bad is it bothering them? You know, if we see something on the MRI that looks terrible, but it's really not bothering them, we're not going to be very aggressive about it unless we have to be. Versus it doesn't look that bad on the MRI, but they can't go to work. Their marriage is falling apart because the pain's so bad.
Right.
You know, all those things factor into how aggressive we're going to be to get them better.
Yeah, you know, I think I see that, you know, not infrequently, and you probably do, that, you know, imaging that we see from patients may not be as impressive as we think they should be, but they really are like you say, their lives are falling apart.
Mhm.
And again, all of my old professors used to tell me that it doesn't take a very big pebble in your shoe to make you limp the rest of your day.
Right.
And so it's not the size of what's happening, it's however that issue that we see on an image is affecting their lives.
Right.
Right.
Yes.
So one of the things that when we start sending patients to pain management doctors, is they say, is it going to hurt? Right? What are they going to do to me? Are they going to give me drugs all to make me better? Or, so how you know?
Yeah, those are all
Right?
questions I hear every day. Sometimes patients feel like they're going to come see us and we're going to want to put them on meds. And really, that's the last thing we want them to do. We really want them to visit us and then move on. Now, some patients have chronic issues that, yeah, they're probably going to be with me for a while. But we look at options of medications. And of course, we always try to avoid opiates. We look at interventional techniques, whether it's epidurals or medial branch blocks, radio frequencies, PRP.
Whoa, slow down there, dude.
Just go into
Slow down. Right, so epidurals, you know, does that mean you're going to stick a needle in my back and I'm going to hurt just like I saw my wife have?
Right, okay.
Right,
good.
what is this?
Yeah, great question. Completely different, but nonetheless, you're right. We're putting a needle in the back and that could hurt. I'd say in my practice, 50% of patients get sedated and 50% don't. The ones that don't, say it hurt for a second, you know, when I numb the skin, and that's the worst of it. But some are anxious, you know, they've been through a lot and more pain is not very attractive to them. So they want to be sedated. So I'm an anesthesiologist, so sedating them is not an issue for me.
Sure.
If they need to get into a deep sedation, we'll take them to the surgery center where another anesthesiologist puts them into a deeper sleep while I do the procedure. Every patient's different. Some need sedation, some don't. You know, we decide with the patient on what's the best
What do you
course.
think the benefit of an epidural steroid injection?
Well, it's so really the patient has more radicular pain. So they're gonna have pain radiating down their leg or their arm.
So like sciatic pain.
Sciatic pain, right?
Like sciatic pain.
Or
Right?
they failed conservative measures like physical therapy or just some over-the-counter medications, rest sometimes. Not too much rest because that can make it worse.
Right.
But, you know, those types of things we try first. And if they're exhausted, we'll try the injection.
Right, and really for all of us, you know, learning about this is really all things other than surgery, because right, so you're doing epidurals, which are shots of steroids, and then you said radio frequency ablation. What's that?
Right. So it's funny because we have the same approach in a sense that we try to be conservative in what we do. So we tell the patients, these are the things we can do before what I do. So, and that's how we define a conservative for us. We'll try the other stuff. And then when that doesn't work, then we get to what I can do. So radio frequency ablation, what that focuses more on the patient that just has axial pain. So just back pain or just neck pain. And we think that pain is coming from the joints themselves in the back. So the spine's composed of a bunch of bones that interact with each other, just like a knee. And so that gets painful just like a knee does. So what we want to know is the pain coming from that spot versus a disc or somewhere else? So first we block that joint with Marcaine, which is a longer acting lidocaine. And then we assess the patient. Patients often say things like, I can't even wash my dishes because it hurts so bad. So we'll do the block and say, okay, go home and wash your dishes to assess, is there a change in how you can tolerate it? And if there is, then we're reassured that the pain's coming from that joint, which then at some point, if we need to, we can radio frequency the joint, which essentially zaps it, puts the nerve to sleep for 6 months to 2 years. And these injections don't have steroids and they're not epidurals. And it's nice that they last as long as
they last a long time when they work. They last a long time. I think, you know, and what I've seen in my practice is really a combination of you guys, right? I think of, you know, the benefits that you get from a patient that comes to see me that's hurt, has back pain or sciatic nerve down the back of the leg or whatever, and is functionally just not doing well. I like employing both of your specialties. On the physical side, assessing, you know, functionality and core strength and weaknesses and work on that. And then on your side of working with pain. But I think really, in our philosophy, is really kind of combining both of you guys together to get the best results for our patients.
No, I agree. It's a team approach. We also feel the same way about bringing you into the picture. Sometimes we tell the patient, look, let's just go visit with Dr. Kuwamura. Let's see what are our options. You know, is it a small little outpatient surgery, or is it
Sure.
a more invasive surgery? And that way we know where we're going in the event we have to do that. And it helps us know how aggressive to be from our end, or how not to be aggressive. If something's bothering them and it's a small miter, that may be something we move towards quicker versus a fusion.
So absolutely. So one of the topics that I want to talk about warning signs for the audience, and I'll just throw some things out, about if we see these things, what do we think about? So now the question is, someone who has back pain and they say, doc, I don't know what it is. I'm trying my hardest, but I've lost 30 pounds in the last 3 months. And, you look great, guy, but why are you losing 30 pounds? What are some things, Jason, what do you think takes first? What do you think, what's the first thing that comes to mind when someone says, I've lost 30 pounds and I got some really bad back pain?
I mean, first thing for me is something invasive, especially if they're not trying to lose weight. That's the concern. So they're not trying to lose weight and they have back pain, maybe a cancer.
Yeah, right. What do you think? Cancer, infection?
We got to roll out those major things first.
Those are the warning signs for us when the patient comes and tells us those things. Just like fever, right? When someone says, "Hey, I have back pain, I have fever," what are you thinking?
Right, immediately then infection. So we're wondering if anything's contributing systemically to the back pain.
Absolutely. Recent injuries, of course, and injuries, either a sports injury or a car accident or some type of industrial injury. Those are, I think, important things to determine. And so if we get a patient that has, that you see a patient and say, "Hey, look, I was in a car accident and I now have back pain." I mean, what are some of the things you're thinking about injuries?
Yeah, trauma, fractures
or things like that.
Instability. Even patients that don't have trauma, though, sometimes will have a spontaneous fracture.
Yeah,
we got to keep an eye out for.
Yes, so tell me about that group.
So, that's probably our older patient with, they're developing weaker bones. And again, they don't have to have a fall or something that precipitated the pain. They just have a severe onset of pain. It seems exaggerated. So you want to make sure you get some imaging. Not always an MRI, even an X-ray can sometimes help, but obviously MRIs are more descriptive of what's going on. But you want some imaging in a patient like that.
Man, you're teeing us up for one of our future topics, which is osteoporosis and compression fractures.
Something that people always forget too is the thing I hear is, well, if I had a fracture, I wouldn't be able to walk in here. But most people walk in with a fracture, especially in their back.
Yeah, no, that's a great point. Sometimes they don't make it to us for months. And then we find the fracture and they've been walking around for a month or two with it.
Right.
Yeah.
Don't steal my thunder for later.
Oh, sorry.
So our next guest is one of our patients. So I'm going to introduce our patient here. Dilian, if you have a seat here and there's a mic for you. And what we're going to do is I'm going to present Dilian to you guys experts. If you guys can do that.
All right.
And I'm going to present Dilian as a patient, almost like our grand rounds used to be. Remember we used to go and you guys are the experts, and I'm going to present my patient, Dilian. Now, Dilian's, just to let you know, Dilian works for us. She is, 35 years old and works extremely hard, and she's come to see us with back pain. And I want you guys to start interviewing her. I have an MRI that we can go through and show you guys. And what I want you to kind of start interviewing her like you would do like a normal patient that comes to your office. And Dilian has back pain that's pretty severe at times. She works an integral portion of our team, and it sometimes limits her activity. And at times she has sciatic pain that goes down your leg. Mm-hmm. So Jason wants to take first crack at her. Some of the questions you would ask her. Yes. And then what I'd like to know also is how do you think you can help her?
Right. So first thing we're thinking is this an axial back pain or radicular back pain? Is it traveling or is it going on? So what we want to know is when you have the majority of pain, where do you experience it?
Right on my low back.
Right across the lower back. And when do you feel like you're noticing this sciatic pain?
When I'm sitting for a long period of time and I get up and then I just like my right leg goes off because now I'm having the sciatic pain.
Okay.
Yeah.
And how long will that generally last for you?
Well, I do certain movements and exercises and stretches, so it could be like for a couple minutes or so until I can start walking normal.
So the exercises or stretches that you can find to do generally alleviate the sciatic pain, then you are stuck mostly with your back pain.
The back pain.
And the back pain. And so at this point, we go through, how long have you had it?
About 7 years already.
And is there anything you do other than sitting for long periods that precipitate the pain? Does heavy lifting or using the restroom or anything drive pain for you, coughing, sneezing?
No, but if I sleep on my side for a long period of time, I get the back pain.
Okay.
If I sleep on my back, I get back pain.
Okay.
Even if I sleep on my stomach, I get the back pain. So it's constant there. Yeah.
Just trying to get around pain at night while sleeping and getting comfortable.
Yeah.
You can definitely understand that. How you do in the morning when you wake up? Does it feel better within 10, 15 minutes or is it an all day?
No, morning's okay.
Morning's okay.
Not that
it's
bad.
the end of the
it's
day.
It's the end of the day
when you start to fatigue and you start to go down. Yeah, so we would take this history and move more into some ortho and neuro testing. We would look for any orthopedic test that would indicate that it is coming from a disc, but from the history, it's sounding like it's more axial back pain and she's getting some referred pain from some of the muscles in her hips that can be putting pressure on the sciatic nerve. She's able to stretch it out and make it feel better and within a very short period of time. Whereas a more radicular pain, we would expect a more constant sort of unable to get away from it. So in our office, we would go through all of the movements. We would check what your ranges of motion are, which ones are provocative, which ones feel better for you, which ones say that that's the spot. And then from that assessment, we'll move in to, if there's no red flags, move into some muscle manipulation and connect tissue manipulation. And usually we'll get some pretty steadfast result, just like she does when she stands up and tries to stretch out.
So this sounds like a problem that's in your wheelhouse that fits into what Urosi can help with.
It's definitely, if she passed on all this, she quote unquote passed on all the ortho neuro tests, which it sounds like she probably, I would expect that she would. It would be safe for us to start with treatment. We wouldn't be too concerned with it. If we came across any flags of the more ridiculous symptoms with those testing, we would bring these other guys in to do a more thorough exam, jump a little deeper into the imaging, and then see if there's any compression on the nerve root.
Certainly. Jason, what are some what are some of the like warning signs questions that you would want to ask?
Warning sign for her? Well, I mean, he covered a lot of it. I think extra that I'd want to know is where does it go down your leg? Does it get it all the way to the foot? Does it?
No, it goes just up to behind my knee.
Okay.
And then it just stops there.
And then you said that you feel it after sitting for a while, but it goes away after you walk?
Yes.
Okay. So, I mean, it sounds like I agree with what he said. It sounds more axial and you're just kind of getting some maybe sclerotogenous referral pain type pattern.
Dr. Barr?
Yeah,
questions?
sure. This is something we always wrestle with and figuring out what exactly it is.
It's hard. Back pain's hard.
And they're not always fitting in one box.
I agree.
As we wish. One thing we'd want to see is any bowel bladder incontinence, anything along those lines?
No.
No, okay. So do you find yourself having to lean forward to alleviate your pain when you're at the grocery store? Do you find yourself leaning on shopping carts to feel better? Leaning forward in the chair to kind of get some pain relief?
Yeah, so that shopping cart sign, so that that's a classic test, right? So tell me about that.
So with some patients, when you have some stenosis, some narrowing in the spine, when you lean forward, it makes more space for the nerves. And sometimes sitting for a long time will press the nerve more. And so if you're leaning forward to open up the spine and alleviate the nerve, there's a possibility you have some spinal stenosis. For that, we'd want to get an MRI versus an X-ray to assess the level of spinal stenosis, if it is there.
Guess what? We have an MRI.
Oh, great. Check it out.
So I'll show you gentlemen her MRI, okay? And then Adam, if you can put her MRI up. Good. And so this is our patient's MRI. What do you guys see?
Pretty patent. I don't see a lot of narrowing on this. Trying to scroll through it.
So what we're looking here is really the MRI of her lumbar spine.
I took it off. I messed it up.
What you messed up? I have to do the same. Jason always has to help me.
I was trying to go through the images.
But the alignment looks pretty good, right? Yeah. So it's not a structural entity problem. Your alignment is good. One of the things I think your discs are good, right?
Disc spacing is
good spacing, so it's not a collapsed disc, and so again, nothing that shoots out and says, "Hey, look, right?"
Good.
Yeah. So we kind of rule out the bad things, which would be infections or tumors or fractures or instability or huge disc herniations. But this is the kind of the world we live in, right? We have a patient here who who has pain. It's affecting her work. It's affecting, you've told me it's affecting sometimes things at home that you do, right? So remember, that's that pebble in the shoe kind of thing, right? Mm-hmm. And so what you think that with her symptoms, mechanical,
I think it would be a good trial treatment, right?
Yeah.
So we start with conservative care and we go through trial treatment. And if within this 4 to 6 week period, she doesn't achieve any result, then we step it up and refer out to look at medications, probably oral first. Mm-hmm. And if that's not successful, we'll go over to more of a specialist to consider if she needs any procedures done within the spine and try to diagnose if we are dealing with anything like stenosis.
What do you think, Dr. Barr?
No, I agree. You always want to try something like physical therapy or Urosi first, chiropractor, see if we can get her better through that mechanism. What have you done over the last 7 years to manage this pain?
I've gotten medications. Mm-hmm. So I've tried ibuprofen and Aleve or Motrin in between. That's pretty much it in some stretches that I've done previously with
so you've kind of been busy trying to manage it, trying to take some pills, get through the day.
Yeah.
Now, one good question would be, when it's really bad, how much Aleve do you take? How much ibuprofen do you take on a bad day?
I would take 2 ibuprofens.
The whole day?
I would say yes, throughout the whole day.
That's good. You know, some patients will come in and they'll say they took 12, 14 ibuprofens in a day. Yeah. Which is really dangerous because, you know, you get it at HEB and you think it's probably safe, but that can shut down your kidneys, give you ulcers, even give you a higher chance for a heart attack and stroke. So those drugs are so dangerous. And a lot of times patients come in saying they're taking 10 to 12 a day to manage a situation like that. So it's good that you're not taking that much.
Even Tylenol in that regard.
Oh, of course,
people don't realize how that Tylenol is over the counter, but can cause serious problems when you take too much.
Cirrhosis, liver damage,
liver failure,
things like that.
Yeah, so that's my concern. Yeah, that's why I don't take a lot.
So for now, you've done some meds, some rest, some stretching at home. Mm-hmm. So yeah, I think starting with, you know, some physical therapy, some Urosi, something to see if that can get her better first.
Sure. So I like you guys working together. I mean, honestly, right. So I see where you're going, and I love that to get her more the functionality. I would say I'd like to get you involved and say, hey, when she identify where the painful areas are and block that pain and deal with inflammation, and then you can do your job, and that pain isn't limiting her to get your goals.
Sure. So how long are your episodes when you feel
them? It varies. It could be from midday to end of day, and it's mostly on throughout the whole night.
But you feel it daily. You never really get a break from this pain.
No.
Okay. So in a case like her, especially, we want to be able to do these rehabilitation exercises, and there would likely be some that are inhibiting for her because of pain. Mm-hmm. And so that's when we run into that situation where they can't perform the exercise or the stretch or whatever maneuver we want to do with them. We know that we need to get some assistance and some pain relief so that we can do what we need to do to make the changes. So that's when we make a referral out to Dr. Barr.
Yeah, I think that. So you're. These guys can help you, right?
They do help out quite a bit. You know, even sometimes see stuff we didn't see, where they'll say, you know, this patient might have some sacroiliac pain, even though we're focusing on the spine in this conversation.
Yes.
They'll send a patient back. If I send them in for therapy, they'll kind of come back with, think about the SI and let's look at that, and sometimes treat that as well.
And there's so much overlap. We mentioned earlier that bending forward can be a sign of stenosis, but it can also be a sign of facet. Mm-hmm. It can be a sign of SI joint pain. And so there's just, you know, like you mentioned earlier, it's not cut and dry. Sometimes you got to kind of try things and see how it works before you can figure out where it's coming from.
Yeah. And one of the reasons we like the recommendation of Dr. Ybarra is that's generally how he practices. Is he gets pretty specific into, we're going to see if this very specific injection alleviates your symptoms, and we've identified your source, as opposed to this big shotgun approach where he just gives a bunch of medicine or a bunch of injections all over the place. So it's a very specified way of identifying the source of the pain, which makes all of us more acutely aware of what we need to do to try to help her live with the pain or manage the pain so that she's not living with it.
Oh, absolutely. Yeah. I think once we find that they identify the why, she's telling us the what. Mm-hmm. Our job is to find the why, and once we have the why, then we can kind of attack the why with all our different programs.
Mm-hmm.
Right. Yeah. So I think thanks, Dill.
Thank you.
Thank you.
You have to come to work tomorrow. So I
you need to know.
We have some questions from the audience.
Yes, we do. Are you ready for those now?
Sure.
Wait, is this live?
What's that?
Is this a live thing?
Yes.
Okay, so a question here from Ted in San Antonio.
Hi, Ted.
He says, sometimes I have back pain in my lower back and sometimes it's my upper back. What could be causing this?
Dr. DeRoche, yeah, jump
Well,
on
we
that
have some muscles that go along the course of the entire spine. These are your postural muscles that kind of maintain how you're sitting and what's going on. So we would obviously dive deeper into your history, find out what type of fatigue levels you have. It is different vertebrae from the lower back to the upper back, and they do move slightly differently, but we check for posture, check for core strength, check for the ability to move, look if you have any abnormalities like an increased amount of curvature that may be there, or scoliosis and history that way. So the muscles are the things that sort of extend that entire length of distance. When we're looking at a lot of nerve pain, we'll see pain go south, right? So if we're looking at nerve pain from our neck down our arms and our back down our legs, and so if we're jumping back and forth between the spine and some different areas and different load-bearing portions of the spine, we want to work on strengthening the muscles that maintain the posture.
Absolutely. Yeah, we're all connected, right? One bone's connecting the other,
Yes.
and these muscles are really long. So
Yes.
I agree, Dr. DeRoche. That's a good point, that when there's two areas, you think about muscle first. And, over the last 6 months, we've seen a lot of patients come in with deconditioning, young, healthy people. That
Right.
Last year, you couldn't go to the grocery store, you couldn't go to work, you couldn't go see your family. So just regular activities that kept you somewhat toned are now off the table. So a lot of people got deconditioned, and now they're getting back, and these pains, specifically these types of pains, they're walking in with.
right.
Yeah, that's exactly what I tell patients too. When it's jumping around, it's muscle. So
Certainly.
Yeah.
there's more to it than most of the time. There's not a mid back problem. It's more of a muscle problem coming from one of the other areas.
Excellent. Any questions?
Yes, we have a few more questions. All these were emailed in earlier, but if anybody who's live wants to ask questions, feel free to type in
Yeah,
the
we
chat.
absolutely, yes. And if they could direct it to one of the panel members, we'd like that, or also I'll kind of direct it when the question comes in.
We have one here from Josefina.
Hi, Josefina.
She asks, what lifestyle changes can harm or help my back?
Ooh. You guys want to take one of those?
I guess it just depends on where we're starting, right? So with patients, when I approach them with lifestyle changes, first I could talk about their diet. You cannot outrun a bad diet. So we dive into their diet. How are they eating? How much sugars do they eat? How much carbs? How many inflammatory agents are they eating in their diet? So we'll talk about that for a while. And if we need to, we can bring a nutritionist in to help. That's so important for me and my patients, is what are they putting into their body every day? Second, we look at exercise and what kind of exercise they're doing. What do they like doing? Are they swimmers? Are they like yoga? Do they like walking? So we'll address those issues with them and find something they're comfortable with. And if they need help, then therapy or somebody like that comes in to help teach them what kind of exercises to do. So those are the things that I start our conversations with when we talk about lifestyle.
So eating well, right? Eating well, that's
Right.
important. I think that's non-debatable anymore, right?
Mhm.
Eating well is important for us. Not exposing us to toxins or limiting the amount of toxins for our body, and then being active, right? Those are so positive lifestyles.
And toxins being alcohol use, drug use, things like that. And also stress.
That's a whole different topic we're going to talk about.
Is that another show?
Yes.
That's another show. Okay.
We're going to stress and how it changes us from the hormonal level and pain. And I think honestly that pain, that we become nutritionally deprived with pain.
Mm-hmm.
That's a whole different topic we're going to talk about. But
We have a question here from Melissa Henderson.
hi, Melissa.
And she asks, I'm not familiar with Urosi. Would you please explain what that is and how it is spelled? Thank you.
Well, I think that's right for you, Dr. DeRoche.
So Urosi spelled AIRROSTI, stands for Applied Integration for Rapid Recovery of Soft Tissue Injury. So what we focus on is trying to accelerate the therapy phase that people go through and do it in fewer visits. We do a combination of manual therapy that involves manipulating the muscles and the connective tissues, and then we bring that over into some therapeutic exercises, give you some rehabilitation for core strengthening, and it's an entire therapy experience that's sort of in its own realm that goes through. But we're basically a blend of a little bit of chiropractic and physical therapy mixed together as providers, and utilizing resources from both fields to accelerate the patient's recovery under therapy.
Excellent.
I agree. It's a new innovative options over the last 10 years, right? 10 years ago, you didn't have.
It's relatively new. Our brick and mortar offices are mostly based out of Texas. We're in 4 states. We're in Virginia and Seattle and Cincinnati as well. But we do have a national product now where we can do remote recovery through these telehealth options, and we can help guide patients through a remote platform on which exercises they should be doing, and get semi-diagnosis, or at least be able to recognize if you have any flags that need to be evaluated by a physician and get you into a referral for that as well.
Certainly.
I think that goes back to the last question too, about what you can do. Core strengthening, postural strengthening is so important. I always tell people it's not just when you're in there, you have to do it at home too. And
It's lifestyle training.
Yeah.
Right? It is.
yeah. So,
I agree. Any questions, Victor?
Yes, yeah, we have another question. This one is from Javier. And
Hi, Javier.
Javier asks, is there anything I can do at home to alleviate, any exercise or anything I can do at home to alleviate my back pain?
Well, it's hard to answer not knowing, Javier, what's safe for him or not safe for him.
Sure.
But, assuming that everything.
Would you recommend at least one visit with, someone to assess him and then kind of prescribe something?
Yeah, I think that'd be good. At the very least, his primary care doctor.
To me, the real danger of home exercise, if you haven't seen anyone, is doing something wrong and then making it worse. And so I always tell people, go and get the information. Once you can do it on your own, by all means, but get the information first.
Yeah, I think that's probably the wisest way to go about it.
I think that's not, so Javier, what we're saying is really just come in for a quick eval. At that point, then they can customize a recovery and exercise program for what your goal is. And that's something that I know all of us do. We customize plans for patients. Right. So just not one shop fits all. It's who that person is, problems and goals, that we customize our treatments.
Yeah.
There's so many different reasons for back pain, right?
Absolutely,
so we need to identify where it's coming from. And for some exercises, when I'm delivering exercises, for some patients, I want them bending forward during exercise. For other patients, we want them bending backward, and that can be counterintuitive in some conditions. And so it's good to get a diagnosis, understand what's causing your back pain, and then get some tailor-specific help to
and that prevents the injuries that
Right.
Jason was alluding to.
Yeah.
Absolutely.
Sometimes a small change makes a big difference.
Yep.
In both ways,
We have another question from Henrietta Thomas, and she asks, my back only hurts when I lift things. When I'm sitting or standing, it's fine. Should I be concerned?
Well, anyone?
I guess how often is this happening? Is it once a month? Is it anytime you've been down? If it's pretty frequent, you should at least get it looked into if it's been going on for more than a month, just to make sure it's nothing to be concerned about.
And if it's every time I lift something, that's not necessarily normal. I would consider that abnormal. So worthwhile getting checked.
One thing I would think about is just how you're lifting. And that's important.
True.
We have to lift things in life. It's inevitable.
Right.
I always tell patients, that we want to avoid bending. I'll demonstrate bending at the waist and bending down and lifting like this is probably mechanically one of the worst things I can think a patient can do for their back. So I employ patients to use their stronger muscles, which are your core muscles, your thighs and your legs, which are really strong to lift anything you need to do. So it may be, Henry, it may be just how you're lifting, not what you're lifting, and kind of mindfulness of how your body moves when you're lifting. And of course, anytime you can use something to help you lift, that's even better.
Right.
Okay.
We have a question from John Andre, and he asks, my back only hurts when the weather is bad. Could this be a cause for concern?
I think that's classic arthritis.
Yeah.
We hear about that.
I hear it. I feel I'm guilty of that. You know what? Come in San Antonio, October, November, December, our fronts come in, and I get back pain.
I think that's a lot of people know that too. Our joints are barometers, right? So
sure,
people with knee problems will say the same thing. I can always tell when the weather's changing.
And that's not wives' tales. I mean, that's really, that's people say, oh, that's just made up things. I think I see it all the time.
No, I see it all the time.
All the time. Weather changes.
I don't know that it only limited to that can mean that we wouldn't worry about it. It's still pain, and pain's abnormal. So, you want to get it looked at and addressed.
I agree. It's not something you just blow over.
Right. Anything that lasts more than a few weeks or keeps happening repetitively, we want to find a cause for it. We want to understand why. Your body's not meant to hurt. So when it's in pain, it's an alarm going off that something's not right. We need to figure out what that is, whether that's simple mechanics or whether that's something more serious.
Absolutely. Right. I think pain's not normal, and not just accepting it. It's the bad months of the year.
Yeah.
know what my problem is. I just have too many birthdays and arthritis in my back.
Well, yeah, birthdays get you that. But, I'll tell
Right.
patients, look, something before this got you here, right? How you've been living, what you've been doing got us to this point. And if we don't change anything moving forward, well, that's just going to further move along.
Right.
And so if you have pain with bad weather, or you have pain with bending and picking stuff up, something's going on. And so if we just ignore it, it's just going to get worse. Even if it's nothing to be alarmed about, it's still going to get worse and then become something more critical.
I agree.
Yeah, definitely. And it's not just age, I would say, because I've seen young people with severe arthritis, and I've had 80, 90-year-olds that look like a brand new spine. So lifestyle is a big part.
Mm-hmm. Genetics too, right?
Yeah.
Genetics. I mean, we can't change our genetics.
Yeah.
Anything?
We have a question from Viviana Garcia, and she asks, is medicine always necessary for back pain? And are there alternative treatments?
Well, I think that's your
Yeah,
realm, right?
no, they're not always necessary for back pain. In fact, we try to avoid medicines because every medication comes with a side effect profile that we don't even want to hear. So we try to avoid medications, and some of the alternatives are the things that Dr. DeRoche does, trying to find a better solution to it versus medication. So yeah, no, medications are not always.
So what do you think about the other things? We're seeing a big excitement about natural things like CBD products and other products and natural anti-inflammatories. What are you guys' thoughts about that?
So, CBD, it's exciting because it is natural, but it's still a medication that we're putting into our body. It's getting made somewhere, and its production is always, I always question everything I put into my body, whether it's, growing in the ground, what pesticide got put on it. So even drugs that CBD that are over the counter, I'm always still just cautious of. I want to find out the problem, see if we can find a solution to it versus treating the symptom. But for some patients, let's just say it's arthritis that there's not, they're just going to live with. These are nice options versus some of the other pills that are more detrimental to the body.
I agree. And going toward your diet and things like that, I think that we advise our patients to do dietary changes for natural anti-inflammatories. There's turmeric, cinnamon, garlic. All these things are, and some people are now, counting, well, that's been for some time, alkaline water, a lot of things that are helpful in just living a healthier lifestyle.
Yeah.
So I think that we look at all those things to try to help the patient.
I would say just a caution is that there's a big difference. The FDA regulates our medications. Supplements, there's no regulation. So It's very important to know what you're taking, what's in it. In other words, do your research. Make sure what you're taking is really going to do what it's saying it will do.
100%.
Perfect.
Yeah.
Victor?
I have one more question from Melissa Henderson. Do you think leaky gut is a real thing that can cause back pain?
Wow.
I don't know the answer.
Yeah, that gets real deep into.
I'll start. I
medicine,
think, Melissa, I think that, I can see that a leaky gut syndrome by itself will expose your body to toxins. And let's just say toxins. And toxins will be, our guts are an important organ in our body that take out nutrients, but it also protects us. And so if you have a leaky gut, I can foresee that toxins and inflammatory products would get into your system. Once it gets into your system, it can cause havoc anywhere, and not just back pain, but it could cause actually kidney pain or muscle pain or fatigue. Just think about these toxins now floating around your bloodstream. And I could certainly see a mechanism where a patient has problems with leaky guts.
I think it's cumulative with the fatigue and other things that come with the inflammation, fatigue. They're reducing activity. They're laying down a lot more often. Like you were mentioning earlier, too much rest sometimes not a good thing. And so sometimes with the amount of positions and inactivity that they're doing with this can eventually lead up to this problem.
I think it leads to a bigger question is that other things can cause back pain. So there's a lot of visceral in your abdomen that can lead to back pain. And so that's one of the things that's a red flag that we need to rule out. I've had this happen, that patient comes in with back pain and really they have a gallbladder that's just inflamed and they need to have it removed.
Yeah.
So, there's definite mechanisms for back pain that lie outside the back.
That's outside our spine. And two things that just came to mind. One thing, I had a kidney stone earlier in my life, and that I thought that someone kicked me in the back. And because our kidneys are up here in our back portion there, and they're up higher. And I literally was bent over because my back pain was so bad. And I went to the emergency room and found out that I had a kidney stone. The other thing I'm thinking about for our women audience, endometriosis, or even ovarian cysts. I mean, those are all things that, you know, I've seen in my career. I'm sure you guys have.
Cysts are a big one. Of all ages, I have women come in all the time with back pain, and you get an MRI, and the spine is normal, but they got this huge cyst that's a problem.
Right.
Yeah.
Victor?
We have one final question from Thomas Johnson. And he asks, whether or not I'm having back pain, how often do I need to come for a visit?
Let's start, Jason.
Sure. I think you have to be evaluated first. So once you get started, we see what's causing the problem, how bad it is. You know, it varies in what our plan is. If we're going to go through something like Urosi or physical therapy, then usually that's a type of thing that each visit builds on the next. And so it's usually a multiple visit kind of thing. Maybe you can kind of enlighten us.
What do you think, Dr.
We do try to speed it as much as we can with a traditional therapy sense. It's 4 to 6 weeks of therapy, anywhere from 1 to 3 times a week, depending on the severity and what we're working with. But we always do try to keep the visits to an absolute minimum and do as few visits as we can while we make the most progress possible. So there's a lot more education for patients now, and home exercise once they've had the instruction in the office on how to perform it, so that they can continue their therapy along during the plan and reduce the number of visits that they have to come in.
Sure.
I have a question for
Sure.
you along those same lines. Is you hear patients come in all the time and they're like, how many injections should I have? There's people that say 1, 3, should they be a week apart, a month apart?
10 better than 4?
You know, so maybe you can, as from a visit standpoint, you know, give us an idea of
that's always a question. How many do I need? How many, you know, first, you know, we tell the patient, assuming you need one, how do you respond to that one? You know, I call them my one and dones. My patients to get 1 injection, their pain's gone. Well, we're done because we don't need to do anymore. Your pain's gone. But there are limits to how many we can do, right? Particularly with steroids, we want to limit how much steroid you get exposed to. So patients will sometimes see me for their back. They'll see the shoulder doctor for their shoulder and so forth. And everybody's giving the steroid. So we have to keep track of everybody getting what they're giving the patient. So we try to limit how much steroid a patient gets exposed to. And so that's kind of how we decide on what a patient's getting and how we use the injections. And we try to limit them and to keep them safe.
Yeah, I think that mindfulness of all of us, because you're right. A lot of times we see patients have multiple problems. They're seeing a lot of specialists, and I know you do a good job of keeping tabs of how much drug they're getting and steroids, which is really important.
Right.
A little bit from me is, and a little bit from you, and a little bit from you, and a little bit for you. I mean, that's a lot.
Right. It adds up. So we have to be careful.
And I think that speaks to the specialty, because all the time we get patients come in and can you do this X, Y, Z? And it's like, no, that's why you have the pain doctor, so that everything can be managed appropriately.
But one of the things that, you know, it became apparent, we all have different perspectives. We're all of our specialties or perspectives. And I think that from the back pain patient person, you know, that comes and sees us, it's just not one answer, right? It's all of us working together to the benefit of our patients. And so that's one thing I think I've become aware more in my practice, and having a specialist like you that I can rely to help my patients. It's all of us working together for that patient to get to feel better.
Absolutely.
Any final questions? No. So I'd like to thank everyone for being, you know, all guests tonight. And Jason, you had to come.
Thanks for having us. Yeah.
Thank you.
But thank you for coming. And so again, I hope you found this show beneficial in some way. It's just starting the topic and discussion. We're all available. Dr. DeRoche, can you say where your office is at?
My office is in Stone Oak and San Antonio on Santero Boulevard.
And Dr. Barr?
Sure, we have 3 locations in Westover Hills, Spurs Lane Medical Center, and Stone Oak here.
And Jason, where are we?
We're in Stone Oak, and then we're in Medical Center off of Fredericksburg. Yeah,
so any patient that has, any person out there that wants an evaluation with our specialists here, they're more than welcome to see you and to, again, and see you, evaluate you, and provide, you know, services that hopefully you can answer their questions, evaluate them, and treat them. I thank all our guests tonight. Thank you so much. Our next topic that we're going to talk about are some surgeries that we're going to talk about, a microscopic discectomy. So we're going to talk about what's microscopic, what's minimally invasive, and what do we really do. And we're going to have some patients that have had surgery and some video and kind of go through things. Other topics are coming up, or cervical neck pain. And we'd probably like to invite Dr. Roche to come back and talk about how we treat neck pain, and Dr. Ybarra come back and talk about how we treat neck pain as opposed to back pain, and there's a difference of that. So again, for the audience, thank you for joining us tonight. Be safe, and again, stay tuned for more shows coming.